Good evening, everyone. Thank you so much for joining today's webinar. I'll be your moderator today. My name is Mary. I work with Passport Global Consultants, and I have seen a good number have already joined. So I'm going to introduce to us the speaker for today, who is our Nclex tutor. Just to give a brief introduction of who is going to be our speaker today, we have his name is Humphrey Njue Konke. He's our programs director. Humphrey is a University of Nairobi alumni. He graduated in 2013 with a Bachelor of Science in Nursing. He is also an Nclex passer. He successfully passed Nclex in the year 2020, and he's licensed in in USA, specifically in Texas. And then he's a coach. He supports in our classes. For those who, I'm sure those who attend our classes or those who are our students have interacted with him in various classes. So he's going to be our tutor today in today's class. So I want to welcome him to start the class. Karibu sana, Humphrey.
Okay, thank you so much, Mary Sylvia, for the introduction and also for welcoming the attendees. Please, may I have people confirming whether you can hear me? You can send me a message on the chat box, and it will be good. So I want to start the lecture. Thank you so much. I can see confirmations. I always want to see the confirmations before I start teaching, because it helps me to know that I'm not alone. So today we are going to handle one of the classes that you guys requested. That is ECG, cardiac rhythms, a very interesting topic. And we are going to start with a question. I'm going to project a question, then you are going to tell me the answer. I will be doing a presentation in the next 1 hour, that is towards 8 p.m. And I'll be majoring on the most important concepts you need to know in ECG. ECG is a very wide topic, by the way. But at Passport, we major only on what is going to be asked in the exam. So I'll be doing a presentation towards the end of the hour, and then we shall do a conclusion in the last, after 8 p.m. So I want to start by projecting a question, and then you tell me the answer on the chat box. Once you tell me the answer on the chat box, we can start lecture itself. The question is already presented there. You have 1 minute to tell me the answer. If you think you need to say the reason for your answer, it's still okay. I'm going to allow you to do that. So that question is going to actually tell us, do we need this class or do we not need this class? So if we can have people, about 80% of the people in the meeting giving the answer, it will be very good to us, okay? So far, not even a single answer received. No, one person has answered. Okay, one person has given the answer. You can, when you're giving the answer, you can tell me the answer is C because of this, just a very short statement. The answer is D because of this. The answer is B because of this, A because of this. Just tell me the reason for the answer you have chosen. It also helps to know how you are reasoning out your answer. Then remember, we also have a question and answer section, not session. Question and answer section on the Zoom. We have a Q&A section on the Zoom meeting. You can send your questions there just to differentiate them from the normal chat. so that we'll be looking at them. Like now when you are answering the questions, I would be looking at them. Yeah, so we don't want to leave anyone behind. Give me the answer. I'll give you a few more seconds to give me the answer, and we shall be able to proceed. About 10 people have given their answers, and we are quite many, so I would expect more people to give their answers. Okay, give me more answers before we go to the next item. This one, a good number of people have it right. I like that. And also for those who have written the reason, your reasoning is very right, very right. Okay, more answers, please. They should be raining. The answers should be raining. It's more than 1 minute now since I posted that question there. So the answer, okay. All right, that's enough time for that question. So I assume that those who have not answered probably don't know the answer. Can I assume that? So about 16 people have answered. The others have not answered. So those who have answered, majority of them have it right. But we are also worried about those who have not answered. So when I give you the next question, within 1 minute, just give me the answer. Or after 1 minute, I'll add like 20 seconds, give me the answer. Okay? So the answer for this question is B. We can give more explanation later, but those who said the interval is within the normal range are very right. The figures are within the normal range. Those who said that are very right, but I'll give you an explanation about it in the notes. Let's try the second question, then we can go to the presentation. Let's try the second question, then I can give, we can go to the presentation. I think I'll give you another question, 3 questions, then we go to the presentation. So just read that question carefully, give me the answer and the rationale. You don't need to type so much on the rationale, just give me a simple reason why that is the answer. Give me a simple rationale why that is the answer. Just a very simple one, shortened. Okay? I will be happy to hear from you. The question says, while monitoring cardiac output, while monitoring a cardiac patient, the nurse notices a change in rhythm. The new rhythm shows heart rate of more than 100, okay? Narrow QRS complexes, and no P wave. The nurse correctly identifies the rhythm as what? Is it a sinus tachycardia? Is it a ventricular tachycardia? Is it a supraventricular tachycardia? Is it a ventricular fibrillation? Okay, so we have some of you are getting it right. We also have some who are getting it wrong, but I appreciate that you have given the answer. Okay, let's have more answers. I would also like to know, for those people who are not giving the answers, is it because you don't know or why? One of the people who are not giving the answers for question 1 and 2, tell me why you are not giving the answers, because I wanted to get some statistics to understand where we are. Yeah, so that I can know how to, what to measure on in the presentation, okay? Yeah, so the answers are coming in, the answers are continuously coming in. At the end of my presentation, you will have understood what should have been the answer to this question, because this question has some major concepts that you should know under ECG rhythms. This particular question. Thank you, Marceline. I've seen you have responded to what I have asked. Okay. Someone is saying I'm very poor with Rythyms. That is why I joined this session. Thank you so much for being honest. Yeah. I also want to hear your expectations. Actually, you can send me your expectations on the chat box. What do you want to know? Which particular rhythm gives you a lot of problems, or what types of questions under ECG gives you a lot of problems? You can give them. You can send them to me so that I can know how to teach them. Yeah, it's not a must I do the presentation the way I have in the notes. I can even concentrate on what gives you a lot of problems. Like the first question, the response was very good. Many of the people who answered got it right. So even if you don't know the answer, you should give the wrong answer so that I can know where we are starting and how we should focus on the question. Okay? All right. The ECG rhythm to be delegated to floating nurses. Okay. All right. Thank you so much. The answer to this question is C, supraventricular tachycardia. I will be explaining to you why it is supraventricular tachycardia and not any other. And I can also tell you that most of the times I give that question to people, they get it wrong. But when I give it to people who are almost doing their exam, they get it right. Almost doing their exam at passcode, they get it right. Okay? Now, the reason they get it right is because they have prepared well under ECG and they have been prepared well. And I can tell you that is not a very simple question under ECG. Some people think that a standalone question is always a simple one. No. A standalone question is not always an easy one. You can have a standalone question that is hard. A hard question. How do you pass Nclex? You pass Nclex by answering the hard questions. So the previous question we have done is a hard question because it needs you to combine a number of concepts for you to get it right. But once we do this session, you're going to realize that it is actually not very hard to get it right. So let's do this one being the last question, then we go to the presentation because it also has some very key concepts that I want you to know. And the ECG. Hamed, I don't see where I can answer. You just go to the Zoom chat. Go to Zoom chat. It's the icon for chat is just down there, and you'll be able. You just click it and you type your answer to hosts and panelists. This is a better opportunity for me to study ECG. Okay. Okay, Monene, I've seen your concern, but you will learn one or two, three things, maybe not everything, but the ECG we teach here in this class, we mostly focus on what is usually asked in the Nclex. Okay? So tell me the answer for question number 7. But Monene, you're going to learn something, so you can stay put. Okay, tell me the answer to question number 7. And if you can give me the reason, I'll appreciate. Because this concept, I told you someone who is almost doing Nclex is someone is doing Nclex and passing is someone who should be able to teach people who are preparing for Nclex. So tell me the answer and the reason. Because if you'll be having your student and then they ask you why are you saying this is the answer, you should be able to tell them. That is why, even if you look at your question bank, it has the answer and the rationale. It has the answer and the explanation. Why is this the answer? Why are you saying this is the answer? Okay. So keep them coming. I'm adding you 20 more seconds to give me the answer to that question, and then we shall go to the presentation that is going to tell us which are the answers. So far, out of the 3 questions, how many do you have correct? I'm going to show you the answer for this one, and I would like to note you. I would like you to note How many have you gotten right? Okay, so the answer to this question is C, prepare for synchronized cardioversion. Synchronized cardioversion is as well highly tested in the Nclex. And the person who has said second line treatment for symptomatic tachycardia, I like the fact that you are bringing up the issue of first line, second line, last line of treatment. That is very important when you're talking about synchronized cardioversion, because synchronized cardioversion you don't administer to any patient who seems like they need it if you have not evaluated what is the performance of your first, second intervention. I'm going to talk about that in the presentation, and that is where we are going to now. Okay. So let's now go to the topic, and we will answer those questions as we do the topic. We are going to answer them as we do the topic. Okay? Cardiac rhythms, ECG rhythms, there's much I can say, but I will go directly to the topic itself. So what are the objectives there? The first objective for me, I want you to know the normal conductivity of the heart. Normal conductivity of the heart. Some resources or some materials, some books, even some tutors may not go to helping you know the normal conductivity of the heart, because number one, they will assume that you already know it, because this is basic physiology that you're supposed to learn in school. But again, physiology was not the favorite subject for every person. That is assumption number one. Assumption number two, many questions are usually not linked to normal conductivity of the heart. But the reason why I include normal conductivity of the heart here is because the moment you understand normal conductivity of the heart, it becomes easier for you to answer questions on ECG. Becomes easier. Some of the Nclex books don't talk about normal conductivity of the heart, but it becomes easier if you understand the normal conductivity of the heart. So like if I ask you, where is the sinoatrial node located in the heart? And what is the work of sinoatrial node? Where is the AV node located in the heart? A physical location. Yeah. And what is its heart? Which are the auricles? Which are the ventricles? How do they help you to understand ECG? And then how does the electrical conductivity of the heart work? Where are the impulses initiated? And then how do they travel to the other parts of the body, to the other parts of the heart? We are talking about electrical conductivity of the heart, not the body. And if the initiator, the original, the natural initiator of the electrical conductivity is not working, then who initiates the electrical conductivity that brings about a beat of the heart? That's very important. So number one, I want you to know the normal conductivity of the heart. Number two, I want you to know how to identify the strips. Number three, I want you to note carefully the words used to describe each arrhythmia and dysrhythmia, because sometimes it is the words that have been used in a question that will help you to get to the answer. So when you're doing ECG, don't concentrate only on the appearance of a rhythm. And you are happy that you're able to identify the rhythm. No, I want you also to know the words used to describe the rhythm. And if you are noting somewhere, because I can remember some off-head, I want you to note, am I still on? Oh, okay. I want you to note some words that are important when it comes to ECG. I'll give you others later as we continue. But there's a word that they use called irregularly irregular. Irregularly irregular. There's a rhythm they describe as being irregularly irregular. There's another one they describe as chaotic disorganized. Chaotic disorganized. So chaotic, disorganized, there's a rhythm they use that to describe. There's another rhythm they use, camel hump appearance. Camel dash hump appearance. There's another one they use, saw-toothed. So they also use saw-toothed to describe another rhythm. And I will give you more words as we proceed. So those are some that can easily help you to understand what they are talking about, because sometimes they will not give you the diagram. They will use the words to explain, okay? You are supposed to use the words to get to your answer. The next thing I want you to know is to estimate, how to estimate the heart rate, because you'll be able to know whether the heart rate is normal or abnormal. And if it is abnormal, is it lower than the normal or it is higher than the normal? Is it a brady? Is it a tachycardia? Then you want to understand what the strips mean. That means that you need to be able to interpret the strips, the ECG strips, and also what you should do as the nurse or as the healthcare provider. And you also need to be able to identify these arrhythmias. That when you see a particular rhythm on the cardiac monitor, you need to understand what is happening to that patient and what you are supposed to do to that patient. We may not be able to get to all that, but this is like an introductory lecture that allows you to understand what are the things that I should know in regards to ECG. Now, how this will be tested is very important for anyone who plans to do Nclex in the next few weeks or months. Number one, knowing how to identify the rhythms gives you a head start in almost every question in the ECG segment. Description of the rhythms, I've told you that you should master the words used to describe the rhythms. You need to be able to identify the PR interval, QRS intervals, and know what they mean. Interventions for sinus tachycardia, sinus bradycardia, and or arrhythmias, and interventions for dysrhythmias. And you should be able to distinguish between synchronized cardioversion and defibrillation, because that's another thing. Like when we are talking about synchronized cardioversion and defibrillation, there are a number of issues related to patient safety. And you know, Nclex is a safety exam. So a good number of relate to you as the nurse who is administering the synchronized cardioversion or the defibrillation, and the safety of the team that you are working with. Like a simple thing, like reminding your team to clear off the bed before you do the shocking. It can deny you a mark in the Nclex, and that is not really good. It is a very small thing, but if you forget it in the Nclex, you lose that mark. BLS and ACLS concepts, for those who have done BLS and ACLS, advanced cardiovascular life support, you know that it helps you a lot when it comes to ECG rhythms. And you know, ACLS is usually a rushed course. So sometimes you guys see it to be very complicated because it is rushed. They usually try to do it within very few days. And sometimes they don't give you the opportunity then to master everything that is needed. But here in Nclex, we give you enough time to understand and master what is needed under ECG rhythms. What we are doing here is not ACLS, but some ACLS concepts are needed and actually tested in this segment of the Nclex examination. So this diagram that you can see on the screen is very basic, very basic in understanding the physiology of how the heart works. And that background knowledge will be very important for you when you are answering Nclex questions to do with ECG rhythms. You will be understanding what is happening. When you are told that the natural pacemaker failed, you'll be able to understand then where are the beats coming from and what kind of beats are we expecting? Is this supposed to be a super beat or very slow beats? Okay. So on the right side here, we have what we call the sinoatrial node. And the sinoatrial node is basically the pacemaker of the heart, the initiator of impulses. The impulses are initiated naturally by the sinoatrial node. That is the pacemaker of the heart, which never stops unless in an abnormality. And some of those abnormalities are the ones that we'll be talking about then in this lecture when we are talking about abnormal ECG patterns. So the sinoatrial node starts the beats. And then once the sinoatrial node starts the beat, and sometimes you may ask, how does it start the beat? The other thing we need to know even before we go to how it starts the beats is this word, automaticity. Automaticity is the ability of the heart muscle to beat without being triggered to beat. It just beats naturally. The beats start naturally, such that when the sinoatrial node, sinoatrial node is a tissue of specialized heart muscle, which is the natural pacemaker of the heart. If the sinoatrial node fails, because then the work of the heart is to beat and produce that effect of pumping blood to all the parts of the body. If the sinoatrial node fails, then another part of the heart muscle takes over, most likely the AV node. But any other part can start a beat within the auricles or even within the ventricles. And that is how you actually get some of the dysrhythmias that we'll be talking about. For example, when someone is suffering from atrial fibrillation, is because the sinoatrial node is not beating or is not beating normally, having so many other parts of the auricles starting beats, and therefore the heart beats in a disorganized manner, okay, leading to a situation that we call fibrillation. It is fibrillating, it is not beating. So that comes from the automaticity of the heart muscle. But the automaticity is there and well coordinated as long as the sinoatrial node is working normally. But once the sinoatrial node is not working normally, because the work of beating has to be done, the other parts of the heart takes over. The sinoatrial node could be non-functional, and then the AV node takes over. But then if the AV node does not take over in a structured manner, many other parts can start beating, and you have the fibrillation. Now, if the parts of the auricle will not take over, you can also have the ventricles taking over, the initiation of the beats. And that gives you the reason why I have included the rates at which the different parts of the heart beat at. So the sinoatrial node, being the natural pacemaker of the heart and being the initiator of the heartbeat, the sinoatrial node beats at 60 to 100 per minute. And you know what? That is where you get the heartbeat. Because the heartbeat naturally originates from the sinoatrial node. So when you are doing ECG, the heart, knowing the normal heart rate is very key in answering questions. And the normal heart rate comes from the SA node, sinoatrial node, who is the natural pacemaker of the heart. So when you're doing an Nclex question and they tell you that there's a problem with the SA node, you obviously expect that the heart rate or the heartbeat will not be normal, because the normal heartbeat comes from who? The sinoatrial node. So if the AV node, for example, has taken over, the AV node initiates beats at 40 to 60 per minute. So obviously you'll have lower heart rate. If the ventricles take over, they usually do 20 to 40 per minute. So the heart rate will be very low. So if the upper part of the heart has a problem, that it is not able to initiate beats, and the beats have to be initiated from the lower part of the heart, you will have very low heartbeats, 20 to 40 per minute, because now it's the ventricles that have taken over work that is not theirs, okay? Initiating the beats, that is what we are talking about. Now, depolarization, repolarization, we will talk about them when we talk about the P wave and the QRS complexes. You need to know them. And once the sinoatrial node starts the beats travel through Bowman's bundle to the atrioventricular node, which is located at the atrioventricular septum. Between the, not atrioventricular, but between the right and left atria. That is where you have the AV node, and you can see it there. I've highlighted it there. Then from the AV node, they travel through the bundle of His to the base of the heart, to the apex of to the lower part of the heart, from where they are distributed now to the entire body of the heart. And then you end up generating a beat. So the movement of electrical conductivity or electrical impulses from the sinoatrial node through internodal pathways to the atrioventricular node, and then from the atrioventricular node to the apex of the heart, then distributed to the ventricles and all the other parts of the heart. So much of the physiology that we are supposed to talk about in regards to the electrical activity of the heart is in this diagram. The moment you understand basic physiology of this diagram, it becomes easier for you to answer some questions. Because like question number 2 that I gave you, there are some concepts that are here. The concept is that when you have beats that are originating in the auricles, then they are likely to be faster than beats that are originating from the ventricles. So that when you have supraventricular arrhythmias, you are expecting that they will have a higher heart rate. When you have ventricular arrhythmias, you are expecting that they are likely to have lower or slower heart rates. I'm not saying that they will be bradycardic in nature, but I am saying normally supraventricular arrhythmias, because they originate from above the ventricles, that is in the auricles, they are likely to have higher heart rates than ventricular arrhythmias, because naturally the ventricles' rate of firing is usually low. The other thing that you will note is that supraventricular arrhythmias, because they are faster, they are likely to have narrow QRS complexes, while ventricular arrhythmias, because they are generally slower, they are likely to have wider QRS complexes. So into your list of vocabulary, add narrow QRS complexes, wider QRS complexes, so that they are also going to help you in understanding the ECG. Someone is telling me come up about the AV node. I said the natural pacemaker of the heart is the SA node. The impulse, once it is originated at SA node, travels through internodal pathways to the AV node. Then the AV node distributes them through the band of His to the apex of the heart, from where they travel now to all the body of the heart, not the body of the human, but the body of the heart, to come up or to develop a heartbeat. And I also talked about automaticity. I think I explained about that. I said depolarization and repolarization. We are going to talk about them in the normal ECG rhythm once now we come to it. But I have said that the basic physiology that is in this diagram is very critical for you because it will help you to answer so many questions. Once you understand what is happening here, it will help you to answer so many questions. Okay? What have you said about wide and QRS complexes? Wide and narrow, wide and narrow. Yeah, I have said a very important concept about wide and narrow. You remember question number 2 that we were doing? I have said here we can see that the upper part of the body pumps at a higher rate than the lower part of the upper part of the heart, that is the auricles, pump at a faster rate than the lower part, that is the ventricles. The ventricles pump at a slower rate. So, because the ventricles pump at a slower rate, when you are identifying rhythms, those rhythms with a wider QRS complexes, whether stated or seen in the diagram, are likely to be ventricular rhythms. For example, they have given you a dysrhythmia to identify, and they are saying that this dysrhythmia has wider QRS complexes. That is a hint that it is a ventricular dysrhythmia. When they tell you it has narrow QRS complexes, you know, when a rate is faster, it tends to have narrow QRS complexes. So when they tell you it has narrow QRS complexes, that is a hint to help you identify that it is most likely a supraventricular dysrhythmia. Let us look at a few slides, then we will be able to understand what you're talking about. The first thing we want to know is what is a normal sinus rhythm. When we are doing physiology, pathology, pathophysiology, we want to know the normal before we go to the abnormal. Now, for ECG, knowing the normal is very, very important because they can test you using the normal. They can also test you, of course, using the abnormal, but they can also test you using the normal. Like question number 1 that we were doing, it was a question about what are the normal ranges, but they don't automatically ask you what are the normal ranges. They bring a question, twist a question, tell you about this patient, tell you what figures the nurse saw, and then it is you to know, these guys, what do they want me to know? They want to know whether I know what are the normal ranges for PR interval, what are the normal ranges for QRS complex. Okay. So the normal sinus rhythm. The word sinus means normal. So even though I'm calling it normal sinus rhythm, when you go to do your exam and when you are doing practice questions, treat the word sinus in regards to ECG to mean normal. Of course, sinus is a word that is drawn from sinoatrial node. So sinus rhythm, even if they excluded the word normal and they just call it sinus rhythm, it means the rhythm that originates from the sinoatrial node. And the rhythm that originates from the sinoatrial node is the normal heart rhythm, because the sinoatrial node is the original or the natural pacemaker of the heart. So therefore, a rate originating from the natural pacemaker of the heart is supposed to be normal, not unless the normal pacemaker of the heart is sick, and it will produce abnormal rhythm. So sinus rhythm originates from the sinoatrial node, and it is the normal rhythm of the heart. How does it look like? The word regular is very important when you are describing ECG rhythms, because a rhythm will be regular or irregular. So the normal sinus rhythm is regular. Both the atrial beat and the ventricular beats are regular at 60 to 100 beats per minute, because it is originating from the sinoatrial node. So you will not see any irregular beats. It has a normal PR interval of 0.12 to 0.20. When you see Nclex anywhere they are dealing with figures, numbers, they really like that a lot. So when you're doing lab values, it deals with numbers. You need to know those numbers. When you are doing pharmacology, medications, where we're talking about therapeutic range, you're supposed to know those ranges. When you are dealing with diagnostics, and you are supposed to know the values, certain values, you need to have them at your fingertips. So when we talk about PR interval, the first question was about PR interval. So someone who didn't know the PR interval couldn't have been able to get that question right. So that is how the normal sinus rhythm looks like in a 6-second strip. I'm going to explain those key P, Q, R, S, T in the next slide. I think it's there. So features of the normal sinus rhythm. The rhythm is regular. You know, sometimes when you are told Nclex does not involve writing, you pick something, you click and pick. Very few areas where you can write in the new generation Nclex questions. You can see we are still emphasizing a rhythm can be regular or irregular. So you need, even as we go through with the ECG, you need to be able to identify which rhythms are regular and which ones are irregular. Because if I ask you about sinus tachycardia, it is likely that someone will tell me it is an irregular rhythm. Yeah, sinus bradycardia. It is likely someone telling me it is an irregular rhythm, but it is not an irregular rhythm. I told you the word sinus means what? Normal. So a normal rhythm is a regular rhythm. I'll show you another one that is regular when it comes to heart blocks, but we are not dealing with heart blocks today. 60 to 100 beats per minute for age-appropriate persons, and a normal P wave usually precedes. That's another thing you check in a normal, regular, normal strip. A P wave always precedes a QRS complex. So if you look at this diagram, you can see in the first beat, we have the P wave there. The second beat, we have the P wave there. Third beat, we have the P wave there. So everywhere we are having a P wave preceding a QRS complex. That's what happens in a normal rhythm. Our PR interval remains constant. The PR interval, the time travel from SA to ventricles, is constant. It doesn't lengthen, it doesn't shorten. And the QRS complex in a normal rhythm is usually less than 100 milliseconds wide. That is 0.11 seconds. So again, the interval for QRS can be asked. I have two questions about that I will show you. I think one, I'll show you one. One was one aspect was included in the first question that we did. But let's go to this figure and see what you're talking about. Now, there is a very important information that you need to understand from this figure. Okay, before we go to the figure, there's something here that you need to know. PR interval represents atrial contraction. When the atrium contracts, that is where we have the PR interval. Then the QRS complex is when you have the ventricular contraction, the ventricular beat, and the T wave is ventricular relaxation. Now you will start asking me, where do we have the atrial relaxation? The atrial relaxation is usually buried in the QRS complex. That is why it is not represented in the ECG strip. So we have these three that are visible. PR interval, depolarization of the atrium. QRS complex, contraction of the ventricles. And then the relaxation of the ventricles, we have the T wave. So this diagram shows it very well. You have the PR interval there. You can see it's the one that is starting there. And this is the P wave. You have the QRS complex, and the QRS duration is shown to you there. And then you also have the QT interval, also important in our discussion. Also note the T wave, because if time would allow, we would talk about T elevation and what it causes, T depression and what it causes, because sometimes the Nclex asks those questions, like the T elevation, myocardial infarction, and so on and so forth. But this information is very important for you, that one small square in the normal ECG strip, a 6-second ECG strip, one small square represents 0.04 seconds. One big square is 0.2 seconds. This information will be important for you when it comes to calculating the heart rate, But one of the easiest ways of calculating the heart rate has been to count the beats. The beats, and how do you count the beats? You check how many QRS complexes you have there. Like in this strip, we have 1, 2, 3, 4, 5, 6. This one would be very easy to count, and then you multiply by 10. So the rate here will be 60 beats. This would be very easy to count because it is a regular rate. So in another lecture, we'll talk about the ways of calculating the beats. We may not be able to exhaust everything here. The types, the methods of calculating the beats, but for now, I've talked about that one of calculating or counting the QRS complexes. It works in many situations anyway. And you'll be able to see which one apply in regular beats and which ones you cannot use in irregular beats. And therefore, for irregular beats, which is the best method for you to use. If it is in this lecture, I'm going to show you, but I have it in a different lecture, in a different presentation. That is what I mean. So before we go to any other thing, I want you to note very few things about the normal sinus rhythm. That the rate is regular. Even when you look at the diagram, it is regular. And it has these qualities or these features. It has a P wave, it has a QRS complex, it has a PR interval, it has a QT interval, and it has a T wave. Okay? Now, I'll be looking at your questions once I give you a question also to do. The questions that you're asking, and then I'll be answering them together. Now, many a times, people confuse sinus bradycardia with another type of heart block. Today, we are not looking at heart block. Let us just concentrate on understanding sinus bradycardia. Now, before you go to the many things that I have written there, I want to remind you one thing that I have said in this lecture, that when you are doing ECG and you see the word sinus, the word sinus means normal. So I am not saying that bradycardia is normal. I'm saying this for the interest of you being able to answer the question that you would face in the Nclex. It is a hint that you are dealing with a normal rhythm. And therefore, because you'll be given that patient with sinus bradycardia and they want you to manage that patient, how do you go about managing that patient? You check whether that patient is symptomatic or not, and you also go for their baseline values. Because you might be brought someone whose heart rate is 58, and it has been 58, 57, 56. So you don't have to worry unless they are symptomatic. So the normal heart rate is 60 to 100 beats per minute. When you have less than 60 beats, we call it bradycardia. When you have more than 100 beats, we call it tachycardia. So between just slightly below 60 and slightly above 100, and we don't have symptoms, we actually don't worry about it. Yeah. But we also investigate, is this usually the normal rate for this person, or probably something is happening? So it is called sinus because it is normal, only that probably there is something or this person is just unique. So in a sinus bradycardia, the rates are usually below 60. P wave has normal morphology. There is always a P wave before each QRS complex. It is a regular rhythm. I don't know whether I've written that there, but a sinus bradycardia, because sinus means normal, is a sinus, is a regular rhythm, because sinus rhythms are normal rhythms. So note that it might be normal in some individuals. So when you see it in the Nclex, don't rush to do some things on people. Just read what you have been given on the question stem so that you can have enough information before you make a decision. So if your client is not symptomatic and you have done some baseline investigations, you have noted that this is normal for this person, you don't need to do anything. You don't need to intervene. No intervention is needed for that person. Okay. However, if that person is having a particular condition and you are giving them some medication that is likely causing bradycardia, you need to be careful with to what extent you can tolerate that bradycardia, or you need to intervene. Okay? So you as the nurse, knowing the cause of the bradycardia is very important. Yeah. Oxygen will be given if needed, and atropine sulfate is the medication of choice in bradycardia. A pacemaker might be needed if atropine fails, but those are in advanced circumstances, persistent circumstances where the heart is actually almost failing. And you will need to do assessments, thorough assessments and approvals for you. We have some slides about pacemakers just ahead of this lecture. So let me just rush over these ones because just normal. Sinus tachycardia, rates of 100 to 180, both atrial and ventricular. It is normal and upright. P wave, of course, is present, 0.12 to 2.0. And then there's a P wave preceding every QRS complex. You know, what this is saying is that it is regular. Yeah? Regular is the word that is described there. In a regular rhythm, you have a P wave preceding every QRS complex. Okay? Now, the P wave may be hidden because the rate is now very fast. The P wave may be hidden in a preceding T wave, bringing what we call camel hump appearance. Now, this is when we were talking in the slide when we were talking about how ECG will be tested. You know, some people, when you tell them about ECG, they will think they will be brought these diagrams and then they will get stuck. Sometimes they just give you the words. So they will describe that a nurse entered a room, found that the rhythm changed, and then when they look at that rhythm, they see a camel hump appearance. what are they describing? They are just describing sinus tachycardia in so many words. So if you remember camel hump appearance, because P waves are being hidden in the preceding T wave, becomes easier for you to identify the rhythm. You know, they can give you those descriptions, then they give you diagrams as answer options. So they give you a diagram for asystole, a diagram for ventricular tachycardia, a diagram for ventricular fibrillation, a diagram for atrial flutter. And then they talked about camel hump appearance, P wave preceding each QRS complex. And now, because you have seen ventricular fibrillation there, and you said ECG is very hard for you, you will say, I don't want my patient to die. This patient is having ventricular fibrillation. Then you shock the patient. You kill that patient and they were not supposed to die. Okay? The other concept I talked about, keep those questions coming. I will answer them. The other concept I talked about is narrow and wide QRS complexes. Okay? So you can see that under tachycardia, we have included narrow QRS complexes. The reason why we have included narrow QRS complexes is because as the rate gets faster, it means that you have many beats congested in a certain amount of time. Okay? In other words, when you talk about heart rate, it is per minute. So the normal heart rate is 60 to 100 beats per minute. Now this one is going up to 180. What do you expect about the QRS complexes? They will be narrow to allow for more beats to be accommodated within that particular minute, as well as shortened QT interval because of the many QRS complexes. Okay. So the treatment of tachycardia, we want to identify and treat the cause, but now, because this is like a basic lecture that is supposed to tell you what to do to ace ECG. When you talk about the treatment of tachycardia, we are talking about knowing and treating the cause. But what about before the cause is known? Okay. First line treatment, we do cardiac maneuvers. If the cardiac maneuvers do not work, we go to medications. If the medications do not work, we go to synchronized cardioversion for tachycardias. First line treatment, we do cardiac maneuvers. If cardiac maneuvers don't work, we go to medications. If medications don't work, we go to synchronized cardioversion. So that is a very important concept for you to know when it comes to the treatment of tachycardias. We may not have time to go through all those, but I really need you to master that for tachycardias, we have that protocol of management. We have that protocol of management. Now, supraventricular tachycardia, fast heart rate originating in upper chambers. Now, another very important concept for you to know from today, if you didn't know, I want you to know this. When you hear supraventricular tachycardia, the word supra means above. Okay, how do you identify this one? Ease of identifying. The word supra, supra means above. So supraventricular means above the ventricles. So supraventricular tachycardia is a tachycardia that is emerging from the auricles, because the auricles are the ones that are located above the ventricles. So if this is a supraventricular tachycardia, you expect obviously that the rates will be so high as opposed to ventricular tachycardia, because we said dysrhythmias that originate from above the ventricles will usually have a faster rate than those originating from below the auricles. So ventricular tachycardias will have slower rates than supraventricular tachycardias, because supraventricular tachycardias originate from the part of the heart that fires at a faster rate, even in normal circumstances. Okay? So the auricles, in normal circumstances, fire at a faster rate than the ventricles. So when you have an abnormal rate in the auricles, it is supposed to be superbly abnormal in terms of the rate. I hope that sinks in. So the supraventricular tachycardia will have a rate of more than 150 beats per minute, and it has indistinguishable P waves. You cannot distinguish them. Why? Because of the rate that is very fast. It also has narrow QRS complexes. I told you supraventricular, those that originate from the auricles, are going to have narrow QRS complexes. And then the rhythm is regular. Okay? The rhythm is regular. There is not much that we teach in ECG. It is the basics here that I'm talking about that you need to master. I can tell you up to now, we have already answered question 1 and 2. And those things, I'm emphasizing them here. Now, regular. Now we have come to an irregular rate. Just look at that pattern. It is called atrial fibrillation. So if you're making some notes, write atrial fibrillation. I'm not sure I have atrial flutter here, but I would also want you to note about atrial flutter. We have atrial fibrillation, we have atrial flutter. The basic description for atrial fibrillation is that it is an irregular rhythm. Irregular. It is irregular in an irregular manner. So that is the description that is usually given. And you will most likely see it in your exam. But for atrial flutter, it is described as a sawtoothed. So, msumeno. Sawtoothed pattern. That is the atrial flutter. The atrial fibrillation is described as being irregular. And there's so many other things that you can see we have talked about there. The causes, for example, it is a multiple, rapid, you will see multiple, rapid, disorganized impulses in the atria. Why do we have that? Now go back to the normal physiology of electrical conduction. Do you remember me talking about sinoatrial node? It is the natural pacemaker of the heart. Now, when you have the natural pacemaker of the heart failing, or you have other parts of the atrium becoming deceased and they start firing because of their automaticity, you are going to have disorganized firing. So even before an impulse travels from the sinoatrial node to the AV node, other parts are firing, are starting beats. So what are we going to end up with? We are going to end up with disorganized impulses in the atria. We are going to have, instead of the atrium pumping blood to the ventricles in an organized manner, the atria is going to be fibrillating. Because everywhere in the atria we have beats originating, so it cannot function effectively. It is fibrillating. And the rates are usually so high, 350 to 600 beats per minute, and it is an irregular rate. So because of the fibrillating aspect and that it is not able to pump blood to the ventricles, you are going to have decreased cardiac output. So understanding the physiology of atrial fibrillation is very important because there are so many things that can be tested under atrial fibrillation and atrial flutter, but you need to differentiate them. Now, the other thing that is highly tested under atrial fibrillation and is an aspect of patient safety, because Nclex is about patient safety, is the aspect of a likelihood of blood clotting. Now look what is happening. The atria is fibrillating. It is just shaking the blood, but it is not pumping that blood to the ventricle as it is supposed to do. So there is a likelihood of the blood clotting or even a thrombi forming because the atria is quivering. It is not beating to pump the blood. So that is why one of the aspects that is usually examined when we are talking about the irregular atrial fibrillation pattern is the aspect of a client being on anticoagulants. Why do we have clients with atrial fibrillation, atrial flutter on anticoagulants? We have them on anticoagulants because of the likelihood of the blood clotting, because this blood is not being pumped to the ventricles because the atria is just fibrillating. It is not doing its work. Okay? So, of course, there are other medications that are given to reduce the rate, like CCB, calcium channel blockers, digoxin, beta blockers, but you also need to note the importance of giving anticoagulants to prevent clotting. We also reverse the rhythm using amiodarone and procainamide. So I'm not sure I have the slide for the atrial flutter is here. So atrial flutter is also here. So let me talk about atrial flutter, and then we can have a break. Interventions for atrial fibrillation, you can have that slide and look at it later. But I've talked about atrial fibrillation. Let me also talk about atrial flutter. Atrial flutter, this is important. Saw-toothed shaped flutter wave, because sometimes they give you an atrial flutter, atrial fibrillation as rhythms or diagrams, and then you are confused on how to differentiate them. For atrial flutter, you see something like looking like the teeth of a saw-toothed. But when you look at the atrial fibrillation, you can see you're not seeing something like that looks like the teeth of a saw. Teeth in quotes. I don't know. I'm not sure whether they are called teeth. Now, for atrial flutter, this one originates from a single cell in the right atrium, into brackets, trying to overthrow, in quotes, the sinoatrial node. Yeah, the causes I've written there. The rate is below what we have in atrial fibrillation. That is 250 to 350 beats per minute. The rhythm is regular. Remember, for atrial fibrillation, we have said it is irregular, which actually is used to identify it. So the one for atrial flutter, the rhythm is regular with flutter waves. This flutter wave, saw-toothed flutter waves, are the ones that you will use to identify which one is atrial flutter, which one is atrial fibrillation. Atrioventricular block is likely because of being overwhelmed, and then, of course, comes with decreased cardiac output that can lead to heart failure. Okay? Possible risks, just like those of atrial fibrillation, we have pulmonary emboli and stroke. And here we also give anticoagulants, we give beta blockers, we give CCB, calcium channel blockers. Assess for the need for cardioversion because of the high heart rate, and radiofrequency catheter ablation therapy can also be used. So at this point, I promised to do 1 hour. At this point, I want to invite my colleague to, as we do a break, to just say something if they have, and then I shall take it up for the next few minutes to conclude the remaining commonly tested rhythms. Welcome.
All right. Thank you so much, Mr. Humphrey, for that insightful session. And I would like to encourage anyone who is planning to sit for the exams to take advantage of our assessment sessions. We're here to help test your readiness and also guide you on your areas that you need to improve. So just even as he takes his cup of water, I would like to share a little on how our sessions are. We have a 4-month Nclex program, revision program, that helps us take nurses through the program until we get to know that they're ready for the exams. So we have sessions that we do conduct. Our classes are Monday to Friday from 7 p.m. to 9 p.m. And then we're also able to have live sessions that happen during that time. During the classes, we also give you an online portal where you're able to access the recordings just in case you miss any of the classes and in case you find difficult to grasp any topic or any module that has been shared or that has been taught. You have unlimited access to your portal. So if you want to enjoy this and many more sessions, please chat us. Our numbers are online. I have already shared our numbers on the chat box. You can find us on +254 726 311 477. That is for Nclex. And +254 791 126 717 for any inquiries that you might be having. We also have the registration process. That is a process that allows you to sit for your Nclex exams. And this process, we have our expert, we have anyone who is able to, we have everyone who is able to, we have a specialist who is able to encourage you and guide you through the registration process. We will take you through the CGFNS process application, account opening. We also help you through the board of nursing to assist you in choosing the best board of nursing. We also take you to the fingerprinting process until you schedule for your exams. So we're having an upcoming webinar for specifically for registrations and job search that is next week on Sunday. Please do not miss to join that webinar because we will answer all your questions. We will take you through the process, even for those who are rechecking, those who are looking to endorse their license in different states, those who are looking for direct hires, and those who are asking which is better. Do I go for the agency or do I go for the direct hire? We'll have all those questions answered coming next Sunday. So don't miss that chance. Also, as I want to welcome our tutor to carry on with the lesson, just want to remind us that we're having an upcoming breakfast. This is for Nakuru interns, nurses, and students who are looking forward to explore global opportunities. Please do not miss. It's happening this Saturday on 28th from 9 p.m. from 9 a.m. It's free. So we have a breakfast simply prepared for you nurses who are in Nakuru and its environment. We can have those from Naivasha, Kericho, Nakuru. You're all welcome. Please don't miss that webinar. I'll invite Humphrey to continue with the classes. And next time when you're having a break before we conclude, I'll also invite Sylvia, who will be able to share with us how our classes, the features of our classes, and simply the journey that she works with us because she's our Nclex guide. So Humphrey, please take as minimum time as possible, and then Sylvia will take over from there.
So much. I promise to take minimum time because what we have covered is very basic, and the few basics that are remaining will not take so much time. But I know the attendees will also want me to be a bit not faster so that they can understand the rhythms. So the next rhythm we are looking at is systole, or you can call it a systole. I am not very sure myself about the pronunciation of that word, but systole means that this person has actually died. I mean, but you have to intervene for this patient. Now, one thing I will tell you is that in the US, you do everything possible to make sure you don't lose your patient. You know, in many third world countries, your pulmonary resuscitation is not very common in the world. Cardiopulmonary resuscitation is not common in the world. And that is a very sad situation to even talk about. I mean, it is sad. I think I can say this as a nurse. It is sad. You will find a nurse who has practiced for many years and they don't know how to do proper cardiopulmonary resuscitation. I believe every nurse should be able to conduct proper cardiopulmonary resuscitation. And conducting proper cardiopulmonary resuscitation means that you should be able to assess the need for the same. Yeah. So if you can conduct proper cardiopulmonary resuscitation, say for example, you have done ACLS, you should request a session in your ward and you do a training for all the health personnel there, even the students who are doing practice in your ward. It is very, very important. Because I think you can believe with me that some people will lose their life that probably they would have gotten another chance if CPR was administered. So when you go to your patient and you find that the rhythm has changed to this one, straight line, the best description of this one is a straight line. So this one is not complicated. But because Nclex knows it is not complicated, do you know how they test this one? They test you by asking you what you will do if you find this. Now, a flat line basically means there is no pulse. And the moment you talk and say that there is no pulse, some people may rush to ventricular fibrillation and say that if there is no pulse, what am I supposed to do? I am supposed to shock. So I want you to know clearly that for systole, you don't shock the patient. You don't do defibrillation. You do CPR. You can, of course, when you're doing CPR, you can give medications. So the first thing you need to check to your patients to determine, especially in those lethal rhythms, to determine what they need is to check whether they have a pulse or they don't have a pulse. In asystole, ventricular fibrillation, ventricular tachycardia, checking, assessing for the pulse is really very, very important. Now, ventricular tachycardia. Ventricular tachycardia normally looks like that. And how you differentiate ventricular tachycardia from ventricular fibrillation in the diagram is that this one is a bit more regular in terms of those beats that you can see there. You can see that it is very regular. Normally, you would see it in a myocardial infarction, electrolyte imbalances, mitral valve disease, mitral prolapse, with rates of 140 to 250 beats. You will recall that when we were talking about supraventricular tachycardia, the beats were very high. And supraventricular dysrhythmias like atrial fibrillation, atrial flutter, the beats were very high. Here we have 140 to 250 beats and also wide QRS complex. When we were talking about supraventricular arrhythmias, we talked about narrow QRS complexes. So the intervention for ventricular tachycardia depends on whether the patient has a pulse or not. This is a very important Nclex concept. When you find a rhythm that is you have clearly identified as ventricular tachycardia, and they want to know how you will manage that patient. You will know how to manage that patient by determining whether the patient has a rhythm or there is no rhythm. So when your patient has, whether they have a pulse or they have no pulse. So when your patient has a pulse, you're going to follow the protocol for managing tachycardias. Yeah. So we are talking of cardiac maneuvers. Someone was asking about cardiac maneuvers. I'll say something about that. We are talking about cardiac maneuvers. If they don't work, you go to medications. If they don't work, you go to synchronized cardioversion. That is the protocol. Now, if your patient doesn't have a pulse, so use the protocol for the patient who has a pulse. If your patient doesn't have a pulse, that is an emergency. You are supposed to do defibrillation. That is the management of ventricular tachycardia with no pulse, because no pulse means danger. So these are the ones that are there explained, but the most important thing is what I have told you, because that is what will help you in the exam. Does the patient have a pulse or do they not have a pulse? So the treatment is different for a patient who has a pulse and the one who doesn't have a pulse. We can do that question very fast. Let's do the question very, very fast. You can tell me the answer as well. I mean the rationale as well. Okay. Oh, okay. Yeah. Tell me the rationale. You can tell me one word for the rationale. That one word we have learned it today, and one of you has given it. Rehema. That's you are very right. Nicholas too. Very right. The others, you have it right also, but you have not told me the reason. Mercy, you are right, but fibrillatory waves, you can also fibrillate. You can also have fibrillatory waves in ventricular fibrillation. So there's a word I'm looking for. Yeah. The host, kindly check my message. You enable me to be able to message everyone. Yes. That's the word. Now many people have given the word. That is a very important word as you prepare for Nclex. Irregular. And you can see that it is irregular. It is not irregular in a regular pattern. It is irregular in an irregular pattern. And that is atrial fibrillation. Atrial fibrillation. How do we identify it? The beats, that's a 6-second strip. Even if you count the QRS complexes, you will see that the beats are very high. You cannot even identify a P wave. You can see the quivering, and then the irregular aspect is actually the most important concept of being able to identify this rhythm, because they can only be two. You can have like this atrial flutter, atrial fibrillation, but then atrial flutter is sawtoothed and then it is regular. This one is irregular. Now, ventricular fibrillation is a very important rhythm for you to know. Ventricular fibrillation, very important. Whenever we talk about ECG rhythms, one of the most important for you to know is, of course, the others are also very important for you to know, but ventricular fibrillation is very important for you to know, even for your practice, leave alone your Nclex examination. Because ventricular fibrillation is an emergency. And the intervention for ventricular fibrillation is to defibrillate. So the answer is usually in the description of that rhythm. For ventricular fibrillation, defibrillate. So what is happening when you have a ventricular fibrillation? The ventricles are firing in a disorganized. The word is disorganized. That's not what I wanted. I wanted to underline that. So the ventricles are firing in a disorganized, chaotic. We describe a disorganized, chaotic rhythm. Yeah. So because they are firing from a disorganized, chaotic rhythm, what is the medical significance? The medical significance is that the ventricles are actually supposed to pump blood from the heart to the rest of the body. Now, when you have the ventricles fibrillating, it means that they are not pumping blood, and therefore, since there is no transportation of blood to the periphery, you are going to have no path. So even when you are doing an Nclex question and you see that they have told you that the patient is having ventricular fibrillation, you should conclude that the patient has no path. So someone with ventricular fibrillation, they have no path. So sometimes they will give you a question, describe to you and tell you that the nurse identified the rhythm as ventricular fibrillation. Then they ask you, what is the nurse supposed to do next? Then you see the first option there is assess for the path. That is not correct, because as long as the nurse was able to identify that this is a ventricular fibrillation, it means that the patient has no pulse. That is what it means. No pulse also means no blood pressure. So this is a medical emergency. What are you supposed to do? You are supposed to defibrillate, of course, CPR, and depending on how the question has been brought, you activate code blue. Okay? Very, very important for ventricular fibrillation. So important tips. The P wave is an atrial rhythm. QRS is a ventricular rhythm. When a rhythm is lacking QRS complexes, it is likely an asystole. Wide, bizarre, wide QRS complexes describe VTAC, ventricular tachycardia. Chaotic, disorganized, no P waves. Chaotic, disorganized, no P waves, atrial fibrillation. Chaotic, disorganized, no QRS, ventricular fibrillation. Sawtoothed atrial fibrillation. Camel hump appearance, sinus tachycardia. Okay, I want to conclude there, but I have a few things I want to mention very fast. I've already talked about interventions for ventricular fibrillation. These ones, we may not be able to talk about them now, but I think I also talked about synchronized cardioversion. Please go and read about synchronized cardioversion. They like testing about synchronized cardioversion so much. Someone also was talking about, was asking what are cardiac maneuvers or in other words, vagal maneuvers. But these are non-medical interventions that you do to a patient when they are experiencing tachycardia. For example, you can ask the patient to bear down, but it is not the nurse who does that. It is the healthcare provider. So also go learn about valgal maneuvers, and also go learn about synchronized cardioversion. For synchronized cardioversion, for vagal maneuvers, please note, this is an Nclex concept. It is not the nurse who does them. They are very simple, like telling the patient to bear down. But it is not the nurse who does that. It is the healthcare provider. Sometimes they ask you that question. For synchronized cardioversion, I want you to know three things. Number one, synchronized cardioversion is a treatment of last resort for tachycardias. That's number one about synchronized cardioversion. Because first you're doing your vagal maneuvers, they don't work, you do your medication, they don't work, then you go to synchronized cardioversion. Actually, four things. That is one. Number two, differentiate synchronized cardioversion with defibrillation. Number three, know that when you are doing synchronized cardioversion, your patient must be sedated. They also ask that a lot. Number four, note that when you are doing synchronized cardioversion, you must obtain a consent. When we are doing defibrillation, we don't obtain a consent because this patient cannot consent. This patient is almost dying. But when you are doing synchronized cardioversion, you're doing them in very conscious patients. So you want to get a consent and you also want to sedate them. Those are some of the highly tested aspects of synchronized cardioversion. So we have some other things that a few slides that we may not be able to look at because of time, but I've done my best to summarize what you need to look at. And those are the major rhythms that are usually tested in cardiac rhythms. I try my best to explain the basic concepts that you need to know for you to answer those questions better. I saw there are some questions that you had asked me here, but some of you are talking of go to previous slide and some of the things that I already explained. So host, kindly make me the just enable me to be able to text everyone so that I can see if there is any question that needs me to answer. I can explain on chat as you invite the next speaker for a few minutes. Thank you so much.
All right. Thanks so much, Mr. Humphrey, for that very, very insightful and very engaging presentation. So just go through a few of the comments that have been shared here by the people who have attended the webinar. So someone is saying that we want more of this. Thank you for this session. It has really helped me a lot. Someone is saying we need more of this. I'm just trying to sample the questions that and the comments that have been shared here. Somebody else is saying that is a wonderful lecture. And another one is saying, please come back with a heart block. So this is another, I think this is another topic that they're suggesting. And then someone is saying, please share the slide on important, nipotea tena. Someone is saying so impactful session. So for all this and any other sessions, please join our program. As shared earlier, we said that our programs are online, purely online, so you don't have to be worried. We teach nurses even in other parts of the world, that is in the whole of Africa. We also have students from Philippines, we have students from South Africa, we have students from Zambia, we have students from all over Africa. Please join our website, our session. You can also follow us on our social media platforms. That is on our YouTube. All the links have been shared on the YouTube, also on TikTok, We are also on Facebook. And most importantly, please join our WhatsApp forum. This is where we share all current updates very often. And on our Facebook page, we also engage us. Please engage us. We usually have our Wednesday question and answer sessions every Wednesday. Please join and learn more as you walk through your journey to US. And then finally, please don't. This is just a call to the Nakuru nurses. Anyone near Nakuru or within Nakuru town, don't miss to attend. It's a free breakfast meeting. Please, the venue has been shared. Don't miss. Come and learn more, and especially now that the visa bulletin is moving very fast. Don't procrastinate anymore. Take your chance and start your journey for Nclex just this month or next month earlier. Our next intake is on April 6th. That is when we'll be having our next intake. The March intake is already ongoing, and we've had a very good turn up. We're also encouraging those who have not yet started their journey to join us. April 6th is the date when we're beginning our classes. That is from 7 p.m. to 9 p.m. Live sessions, recorded classes, lots of questions, lots of materials for you to study and to take you through the journey. And also, one thing that I'll be able to share, I want to share with us today is that the unique is how we've packaged our packages. Our packages are so unique, and especially for those 4 classes, we ensure that we give and deliver to the standards of NCSBSN, so that when you're going to sit for that exam, we are sure of the pass rate being high. So please join our sessions, and looking forward. Also, don't miss to register for our next webinar that is coming on Sunday. We will share so much, just as I had said earlier. We are going to share a lot on registration, and those who want to endorse their license, those who are struggling, they want to do a retest, where to start from, and those who also have booked the exam from South Africa or any other center and they want to shift their centers to Kenya. We will be able to answer those questions and also help you through the process. So thank you so much, even to everyone who has taken their time, who has created their time just to be in this class, to enjoy the teachings, and also learn 1 or 2 things. Thank you so much for your time. It's always a pleasure for us to have you joining our webinars. Thank you so much. We can now end the webinar. Someone
Hi.
is saying, kindly admit, yes?
I'm on now.
All right. So I thought you had. And please carry on, and then once you finish with your session, you can now end the webinar.
Okay, thank you. So, hi everyone. I hope you can all hear me.
Yes.
Yes, my name is Sylvia, and I work with Mr. Humphrey and Mary Sylvia, and we are in charge of Nclex at Passcode. And I'd say this is a really good program. But I'm here to tell you what webinar we are having next week. So apart from the breakfast on Sunday with the nurses in Nakuru, and if you're around Nakuru, please you can come and have the breakfast with us. We will also have a webinar on Sunday evening. So the webinar is a webinar on job search and registrations as well. You know, out in your Nclex journey, outside Nclex, we have the registration process as well as the job search after Nclex. So this, what you get at Passcode is a full package. After the classes, we are able to walk the journey with you from the beginning to end. So what it looks like for you once you join our program at Passcode, we after you've done and passed your Nclex, we are also able to assist you with job search. So next week we'll be hosting a webinar on how we'll be talking about what it looks like for you after you've passed Nclex, what you will need as you go in to your next step, which is job search. So job search at Passcode looks like us redoing your CV to international standards so that you're able to secure those interviews easily compared to just going in with a regular CV. We'll also advise you on the best and the best path to take, which visas to take as well. We'll do a contact analysis for you once you have a contact. We'll also do interview coaching and a lot of coaching, just to make sure that when you go into your interviews, you're able to sit through your interviews and pass them. Most interviews are done in 2 phases. There's a first phase, and then there's a clinical phase, which is the actual interview. So we are able to help you prepare for that, and also let you know what it looks like, so that you go into it very well prepared. There's nothing as good as going into an interview and you get a good or a very good contact on your first interview, so that you don't have to keep repeating the process over and over. So that is what our job search looks like, and next week we'll be speaking in-depthly on that, so that you're able to understand what it looks like for you after the Nclex. Apart from that, we'll also be doing 2 sessions on job search and registration. So registrations, what your registrations look like with Passcode, we have really good consultants who are always doing the work behind the scenes, and they're researching and they're up to date on what is happening in the market. So with registrations department, when you come to us, we are able to tell you what state you qualify for, what you will need, and just in general make your process easier. So we will do your transcripts. We will go through them and see which states you qualify for, advise you on how to go through the process. We'll walk with you through the process of verification, fingerprinting, just as Mary Sylvia had said. It's a very long process, but doing it with Passcode, especially as someone who's pursuing Nclex, makes it easier for you in terms of what you will do or how you will go about the process. Also on the registration bit, we have DHL services. We have services where we are able to collect the documents for you and send them over to, similar to DHL, but not really DHL. So we make you moving your documents from here to the US very easy. So even if you're not part of our registrations and might need assistance with getting your documents to the right institutions in the US, please pass by Passcode. We also have fingerprints, the fingerprint cards, which most of you are advised to purchase at Amazon. You can please come to Passcode and we'll give you those as well, so that you're able to make your process move faster, and it's easier when the resources are available locally, as opposed to you having to wait to get the cards from Amazon. So we try and make your process easier all through. So on that, please join our registration and job search webinar next week. It will be very informative. Our consultants and experts will be there to answer your questions, anything you don't understand or you want more clarification on around the process, they will be able to assist with that. So we'll be doing a webinar on that next week. So you're all welcome to join and have a session with them. If you are having a bit of worry and uncertainties around this process, please join. You'll be able to get all the information you need. Our program, Mary Sylvia has shared on that, so I'm not going to share more on that. And I'd like to really welcome each and every one of you to the next webinar. So thank you so much. I think that will be the end of it. You have a good evening and enjoy your night.
Okay, thank you everyone. My name is Ruth.